introduce our speaker. Thomas Neilson Saidie is a clinical psychologist in private practice in Nashville. He earned a BA in psychology from Wake Forest University, an MA in clinical psychology from Appalachian State University, and a PsyD in clinical psychology from Florida Institute of Technology. He has worked in the community mental health field. He has been director of training of an APA accredited internship for psychologists, and he has been in private practice for 24 years. And in 2020, Dr. Neilson was admitted to the California Institute of Integral Studies certificate program in psychedelic psychotherapy and research that he just recently completed. All right, folks, and without further ado, I'm going to turn this over to you, Tom. Thank you so much for joining us.
Thank you, John. Thank you, Melissa. Let me see if I can share my screen. How's that working? Can you see the PowerPoint?
Yes, you're all good.
Okay. So my subject today is psychedelic assisted psychotherapy. Thank you all for coming. There are a lot of ways you could spend your time today, and I appreciate you deciding to come here. You know, you'll get a copy of the PowerPoint after the talk, so you really don't need to take notes. My email is also at the end of the PowerPoint in case you'd like to be in touch about anything that I covered today or for any reason. Also, my PowerPoint includes references to a lot of the published research, so you can, further look up things that might be of interest. So let's see, get started. There we go. It's not advancing. There we go. Okay. So imagine being severely clinically depressed with pervasive feelings of worthlessness and hopelessness, and suddenly having the profound experience of being in God's presence or in the presence of the divine, however you understand it, and being bathed in infinite, unconditional love. Imagine having terminal cancer, being afraid of dying, and suddenly having the experience of being one with the universe, and knowing that everything in the universe, even your cancer and impending death, is, in a sense, perfect. Imagine having severe PTSD for years or decades, and suddenly being able to recall your old traumatic experiences with manageable and sometimes little fear, and with a deep sense of trust in yourself, the universe, and your therapists. These are examples of what often happens in psychedelic assisted therapy. The first two are examples that are common in psilocybin assisted therapy. The last one is pretty typical for MDMA assisted therapy. The first two are also examples of mystical experiences. So Roland Griffiths is one of the senior researchers in the field. He's at Johns Hopkins, and he has said, the psilocybin experience enables a sense of deeper meaning and an understanding that in the largest frame, everything is fine, and that there's nothing to be fearful of. And he's talking about the mystical experiences that people often have in psychedelic therapy. Actually, these experiences, these mystical experiences during psilocybin-assisted therapy are the best predictor of therapeutic outcome. In other words, having the experience, which most people do, and the extensiveness of the experience is the best predictor of a positive outcome in psilocybin-assisted therapy. Now, mystical experiences are common in MDMA-assisted therapy, but they aren't correlated with the outcome, and that's because the treatment works differently, which I'll explain a bit of. So you might be wondering exactly what a mystical experience is. You may also be wondering if it's some kind of new age woo-woo, and wondering what place it has in psychotherapy. So let me say a little bit about mystical experience first. I guess from a psychological point of view, you could call it a type of a peak experience, which is the older word is altered state of consciousness. That's kind of fallen out of fashion. The word used most often now is non-ordinary state of consciousness. So it's a non-ordinary state of consciousness characterized by euphoria. And that's really an oversimplification there, often achieved by self-actualizing individuals, but not just by them. Both the idea of peak experience and self-actualization come from Abraham Maslow. So I figure I need to give you all some kind of definition of just what a mystical experience is, because it's I guess you would say it's a specific type of peak experience. And one of the most important qualities of it is it tends to be ineffable or difficult or impossible to put into words, which makes it not so easy to define. But this is the best definition I could come up with for now. The direct experience of a reality that feels profound and more true than everyday experience. The experience often comes with a sense of awe, beauty, joy, or love. These experiences are meaningful, healing, and they can be life-changing. They have a noetic quality to them. In other words, they're experienced as an intuitive but certain knowing. They also often involved a shift in the sense of identity, knowing yourself differently, for example, as one with everything, or as made of love, or as sacred and divine. There are many different flavors that mystical experiences can come in. There also might be the sense of truly knowing yourself for the first time. They tend to be paradoxical, but the paradox makes perfect sense. An example would be describing a certain kind of mystical experience as, I'm someone, I am no one, and I'm everyone. That sounds contradictory from maybe our typical ways of looking at the world, but makes perfect sense from the perspective people have during a mystical experience. And a mystical experience can be more than a peak experience. A peak experience is wonderful, but it's essentially transient. You reach the summit and then you come down. When a mystical experience is more than that, more than a peak experience, it's the beginning of a new path in life. You go up to the summit, you probably come back down, and it starts you in a different direction in your life. And it can change the course of one's life. And that can happen in several different ways. And I'm going to give you a couple of quick examples. Bill Wilson, the founder of AA, had a mystical experience when he was being treated with a compound containing belladonna in about 1935. So he had had 3 previous hospitalizations for alcoholism. He had always relapsed. This was his 4th admission. Part of the treatment involved this belladonna compound, And belladonna is an atypical psychedelic. I wouldn't necessarily recommend trying to use it nowadays for psychedelic assisted therapy, but it's an atypical psychedelic. And under its influence, he asked to see God and was greeted with a blinding light and an ecstatic feeling of freedom and peace that stayed with him for the rest of his life. And he was abstinent for the remaining 36 years of his life. And something that's not well known, but is true, is that in the 1950s, Bill Wilson wanted, in the 1950s, therapy with LSD was actually fairly common, especially in places like Los Angeles and, of course, California. And Bill Wilson wanted to incorporate LSD therapy into AA. And he was quickly shut down by the AA board, who wanted to have nothing to do with the idea. But it's interesting that he wanted to do that. Another example, Michael Pollan has written a wonderful book that I would imagine many of you have read, called How to Change Your Mind. And it's about psychedelic assisted therapy. And as part of the process of doing research for the book, he went out and had several psychedelic experiences with underground guides. And after these experiences, he took up meditation. And he says something like, so he had tried meditation previously, I think more than once, and it never really clicked. But he said, having experienced the destination of meditation, the practice made sense to him for the first time. And that's a significant change to his life. And who knows what fruit it will yield in the coming years. So if you're a skeptic about mystical experiences, I'll just say, I understand, please bear with me. And if it's more comfortable, you might think of them as just a type of peak experience. So William Blake was one of the most well-known and beloved of the Christian mystics. He was also a brilliant and prolific poet. And if you've encountered him before, it was probably in a literature class rather than a religion class. He said something or wrote something that I think nails the nature of a mystical experience with or without psilocybin. If the doors of perception were cleansed, everything would appear to man as it is, infinite. For man has closed himself up till he sees all things through chinks of his cavern. Please excuse the gendered language. Blake lived a long time ago, but he's essentially saying that the human mind has closed itself up. And in our typical daily consciousness, we're only seeing a narrow slice of reality. He also is saying it's possible to see a larger, even infinite reality. And we'll come back to William Blake later. This quote is also directly relevant to psychedelic experiences. Aldous Huxley, the well-known and respected novelist, wrote a book about his experiences with mescaline, another classic psychedelic. And he titled the book, The Doors of Perception. And obviously took the quote from Blake. So I have a lot of information to share today, but I don't want this to be just a, sharing a lot of information that is kind of research-based and clinically based. I want to give you as much as possible a feel for what mystical experiences and psychedelic experiences specifically can be like. So I've got couple of very different examples for you. So Bill Richards is another senior researcher in the field. He was actually involved in the last research done before psychedelics became illegal, were moved to Schedule I back in the 70s, and involved in the first research when the FDA started approving research again. And his first psychedelic experience was with psilocybin in December of 1963. He was a graduate student in Germany and participated in psilocybin research. It was done really differently than what's being done now. And I wouldn't recommend doing it the way they did it. They basically gave him an injection of psilocybin and had him lie down on a cot in a dark, dingy basement room. We give more attention to set and setting now, and that makes a big difference. And I'll explain set and setting a bit later. But fortunately, Bill had a very positive and helpful experience. And I'm going to read a bit of it to you. To my utter amazement, I soon discovered in my visual field the emergence of an exquisitely beautiful, multidimensional network of intricate, neon-like geometric patterns, drawing my attention ever more deeply within. I could see this display with open eyes, but found that when I closed my eyes, it was even more vivid and sharply focused. I recognized life within the undulating designs and began to feel as though I somehow could enter into the energy flowing within them. Soon I felt immersed in incredibly detailed imagery, best described as Islamic architecture and Arabic script, about which I knew nothing. Then I seemed to fully become the multidimensional patterns, or to lose my usual identity within them, as the eternal brilliance of mystical consciousness manifested itself. Suddenly, this consciousness was experienced as outside of time, a pinnacle from which history could be viewed. My awareness was flooded with love, beauty, and peace beyond anything I had ever known or wildly imagined to be possible. Awe, glory, and gratitude were the only words that remained relevant. He goes on to write about, at some point in the experience, he was afraid he would forget how profound it was, and he thought he'd try to write down something of his experience. And what he wrote is a good example of how hard it is to capture something like this in words. He wrote, "Reality is. It is perhaps not important what one thinks about it." And when he looked at it a few days later, he was really unimpressed that it didn't really capture the experience. So after the experiment, he walked back to his dorm room and just found him and just was moved to lie prostrate on the floor in gratitude and awe. And that's a summary of his experience. His experience has several qualities that are common in mystical experiences: it's ineffable, sense of profound love, indescribably beautiful, awe, and great peace. Really a remarkable experience and pretty common in psychedelic assisted therapy. But it's important also not to be naive or to idealize psychedelics. Let me tell you another story. When I was in my early 20s, I knew a young man about my age. He was actually my boss's son. And when he had been a senior in high school, right near the end of his senior year, someone apparently slipped him a psychedelic. It was probably LSD. It's so potent, it's very easy to, it doesn't take very much to get to to cause a really significant effect. You know, he didn't know it was being done. He wouldn't have wanted it. He had a horrendous night. It was a nightmarish night. And it actually led to a psychotic break. And he spent several years in the hospital. And he wasn't responsive at first to antipsychotic medication. And it was only through combination of the medication, and he was fortunate enough to get connected with a therapist who was really gifted at treating this kind of thing. And she was able to help him more or less back to reality. Oddly, I knew her and didn't hear about her, or I heard about her from him and was surprised that this was someone I knew. So when I knew him, he was relatively stable. He wasn't floridly psychotic, but he had some very odd ideas. He was living with his mom. I don't think he could have worked successfully. And he had actually blinded himself in one of his eyes during one of the psychotic episodes. So that's an example of what can happen when psychedelics are taken under the wrong circumstances. And this kind of thing has happened more often than you would want to know over the years. Also, it kind of highlights another danger. There's a real possibility that he had a genetic loading for schizophrenia, and the psychedelic tripped it off, but there's no way to know. He may or may not have had that genetic loading. It's believed that it's not a good idea to give psychedelics to someone with a family history of schizophrenia or bipolar disorder, and folks with that history are excluded from the studies that have been done recently and that are currently being done. I guess the part of the point of the last story is these are powerful medicines and best treated with great respect. Okay, I just want to say a few words about how I got interested. So I've not had an interest in psychedelics until the last couple of years. I have had a long interest in Buddhism, mindfulness, and mysticism. I kind of came of age in the 70s when everything in the popular press was about how dangerous they were. And it was actually a lot of exaggerated propaganda. But I've had this long interest in Buddhism and mindfulness and mysticism. And I've got a long meditation practice and been to more retreats, meditation retreats, than I can actually count at this point. And in that context, I've had occasional profound mystical experiences that have been life-changing for me. And in some ways have been more helpful to me than the psychotherapy I've received. And I've had a couple of rounds of therapy, and they were very good. They were very helpful. But if I had to choose between the two, hands down, it would be the mystical experiences. And then a couple of years ago, a friend and colleague, Sandy Anders, said to me, "I think you would really enjoy How to Change Your Mind by Michael Pollan." And the book had actually been previously recommended by some family members. So I actually got the book and read it. And I was pretty blown away by it. So people were having, under the influence of psilocybin, mystical experiences that were life-changing, that were in some ways similar to the experiences I'd had, but they hadn't had to do, 30 years of meditation practice or had to go to all of these meditation retreats. And some of them, after having the experiences, suddenly became interested in things like meditation, like Michael Pollan did. So I started having kind of regular meetings with Sandy and her husband, David Yerian. We were all interested in this subject. I later found that a few of actually my pretty good friends in NPI had the same interest, and I had no idea. So I had some conversations with them, and some of you are here today. Thank you for coming. And that led me to enroll in the CIIS program, the certificate program in psychedelic assisted therapy. I highly recommend the CIIS program. If you're interested in becoming a psychedelic assisted therapy and really want to put the time in, it's the best educational experience I've ever had. It's intensive. It's kind of like being in graduate school again. But the quality of the instruction and the professors and the humanistic attitude of the program are just really remarkable. You get to actually learn from a bunch of the leaders in the field. Like Bill Richards, who I've mentioned earlier, I've had several classes with him. So to get to the main event, I had planned to talk first a little bit about some kind of recently discovered issues with antidepressants that sort of make a case for new approaches to therapy like this. But there's really not enough time to do that and talk about everything else I want to talk about in the main topic. So if you want to ask about the antidepressant issues, I'll be glad to address those in the questions and answers. Also, you'll have my email, so you can email me and we can have a conversation about it if you'd like. So there are three main types of psychedelic assisted therapy. There are other types, but the LSD assisted therapy, which was done a lot in the 50s, ibogaine assisted therapy is really promising with addictions. But these are the main things that the main types of psychedelic therapy that are either being done now or being researched. And starting with psilocybin. Psilocybin is the ingredient in so-called magic mushrooms. It's a classic psychedelic drug like LSD or mescaline, meaning that it operates on the serotonin 5-HT2A receptors, primarily. It's a neuroplastic agent, which means it causes the growth of new neurons and new synaptic connections, which kind of makes sense, would be useful if you're trying to change. The early research shows it to be remarkably effective with depression and end-of-life issues. And in 2018 and 2019, the FDA granted breakthrough status to two different agencies working with psilocybin. And breakthrough status is a designation that the FDA gives if a new drug looks, based on early research, like a significant improvement over existing treatment. This will be the focus of most of today's talk. Psilocybin and MDMA are currently on the Schedule 1 list of narcotics, meaning they are technically considered to be dangerous and to have no therapeutic use. In the late 90s, though, the FDA started approving this research. And the research suggests there's a lot of therapeutic use for them. An interesting thing about psilocybin is any mind-altering substance can be abused, but it doesn't appear to have addiction potential. If you put a rat alone in a cage with a bar that will, the rat presses the bar, it'll get food, and another one gets the rat a drug like cocaine or an opiate, the rat will press the drug bar until it starves to death. If you do the same thing and the drug is psilocybin or LSD, the rat will press the drug bar exactly one time and never again. So let me, it's the evidence indicates it's really not addictive. It can be abused and it can do harm, but it's not addictive. Moving on to MDMA, I'm not going to talk much about MDMA. Robert DeSalvo did an excellent talk last year on psychedelic therapy, and he talked mostly about MDMA. So I don't need to say much, but I'll say a little bit. MDMA is an unusual drug. It's a synthetic. It doesn't exist in nature. And it's a kind of somewhere between an amphetamine and a classic psychedelic. It's not a classic psychedelic, but it's somewhere between those two. It's actually a ring substituted amphetamine derivative and a mescaline analog, meaning it's structurally very similar to mescaline. So it's not a classic psychedelic. It's called an entactogen or an empathogen, meaning that it facilitates empathy and contact with oneself and others. The early research shows it remarkably effective with trauma. And it works in ways I think you wouldn't predict from the nature of the structure of the drug. You wouldn't think something that's kind of an amphetamine would quiet or downregulate the limbic system, and it does. The limbic system is the part of the brain that mediates fear, anxiety, anger. After taking MDMA, the limbic system gets very, very quiet. It also causes the release of oxytocin, the bonding hormone, which you wouldn't predict from the structure. And it allows trauma victims to work through trauma with not so much fear and anger, and with the ability to trust again, to trust their therapists, trust themselves. It's ahead of psilocybin in the FDA pipeline. It got breakthrough status in 2017. And actually, I think if it weren't for the pandemic, would probably have been approved later this year. I'm thinking that'll be maybe, assuming the research continues like it is, maybe late 2022. And probably psilocybin's a year or two after that. MDMA is a drug to keep your eye on. It has shown real promise in couples therapy, where the drug is given to both parties, and they have an extended therapy session. And it allows them to bond again and to be less angrily reactive and fearful of intimacy. It's also been used a little bit with some apparent success with autism. Not that it's cured it, but helpful. And I actually had the opportunity to ask Michael Mithofer, who's the lead researcher in this area, if he thought it would showed promise with attachment disorders, and because it seems like it would. And his answer was a very passionate yes. So, the possible uses for MDMA are pretty remarkable. And then the last thing I want to talk about is ketamine. Ketamine is the only option that's currently legally available outside of research studies. So people can get ketamine treatment now. It's also not a classic psychedelic. It's a dissociative anesthetic. And at higher doses, it has psychedelic effects. It's also a neuroplastic agent. It causes regrowth or growth of new neurons and synapses, and gives many people who are severely depressed immediate relief. Not all of them, but many of them. The downside is the effect of one treatment doesn't really last usually, but multiple treatments have more lasting effects. So The rest of the talk is going to be mostly about psilocybin-assisted psychotherapy. And I'm going to talk about practices and procedures, some of the research results. I'm just going to hit a few highlights. The question of how does it work, and this involves a good bit of neuroscience. And I'll touch on a holistic model that I don't think we're just going to have much time for either, but I'll at least touch on it. So practices and procedures. Typically, the client gets several preparatory sessions, and then a medicine session, and then several integration sessions. And the preparatory sessions involve getting the client's history, building rapport, and helping the client develop a therapeutic set. And the set refers to the mindset the client or patient brings into therapy, into the treatment, into the medicine session. And so, a helpful therapeutic set includes things like healthy and growthful goals and intentions. And this also involves educating the client about what to expect, which is really helpful and important, because the psilocybin experience is a very dramatic change from our usual way of experiencing the world. Okay, then there's a medicine session. And this is a 1 day long session. It pretty much takes a whole day. A psilocybin trip, so to speak, lasts 6 hours, give or take. And so it pretty much takes an 8-hour workday to do psilocybin, to do the medicine session. Actually, the researchers, when they started down this path at Johns Hopkins, chose psilocybin over LSD for 2 reasons. There's a lot of negative baggage with LSD. And an LSD trip can last as long as 12 hours. And that's one very long workday. And then there are several integration sessions. And here, the client is helped to articulate and clarify and embody the lessons of the medicine session. And so they're addressing questions like, what happened? What have I learned? How do I live it? And that's a really important one. How do I live it? And the answer to that can be both simple and complicated. It doesn't involve so much of the intensive meaning making that we do typically in talk therapy. It involves some of that, but not so much. It can be very simple, but it also, here's a manual for integration. And you can see there is a lot you can learn. One thing I've found in my training, and I guess I should say, I haven't had the opportunity to guide psychedelic therapy sessions, because the only way you can do that with psilocybin or MDMA is if you're in a study, if you're working in a study. What I have had the opportunity is to see video of real psychedelic therapy sessions, and to see role play by experts like Bill Richards, and to participate in role play as well. So one of the things that I've learned is that it's helpful to unlearn, probably necessary to unlearn a lot of typical traditional therapist habits. The medicine session involves a lot of waiting, attentive waiting, and being prepared to make interventions when they're needed, but an awful lot of waiting. And one of my fellow students, who I worked relatively closely with, is a nurse midwife. And it appeared to me that in some ways her training was more useful than mine. So moving on, set and setting are really important. They can make the difference between a good experience, a healing experience, and a very problematic experience. And set refers to the mindset of the patient. I guess I've talked about that enough. So it's important for there to be a comfortable, safe, and aesthetically pleasing office. There's usually, there's a large couch or a bed in the office. It looked to me like the Mithoffers were using something that looked like a hotel room in their work. So 2 therapists are present, and there's some very good reasons for that. People under the influence of psilocybin are suggestible and very vulnerable. And under the influence of MDMA, they're vulnerable as well. An unethical therapist could easily take advantage. And one way of making that very unlikely is to have 2 therapists present. But there are other reasons too. Psilocybin can make people paranoid. And it doesn't happen in most of the sessions, but it can happen. And it's easier for 2 therapists to deal with that than 1. And in fact, when a client gets paranoid in a session, it's usually about one of the therapists, not both of them. And that allows the other therapist to step forward and do most of the work. Also, occasionally, clients in the middle of a psilocybin session decide they're going to leave. And it's a lot easier for 2 therapists to deal with that than 1. And typically, at the beginning of the medicine session, before the medicine session, the client hands over his or her wallet, car keys, and cell phone, and gets them back at the end of the session. No distractions from the cell phone, and it's kind of hard to drive off without your car keys. And can you imagine, someone under the influence of psilocybin grabbing their keys, running out, getting in the car and driving down Main Street? That could be a real disaster. So typically, clients spend most of the session with eye shades on. That enhances the visual imagery and is listening to music with headphones. And the music is specially designed to shape and enhance the session. A lot of beautiful music is included. The most well-known playlist is the Johns Hopkins playlist. They actually have more than one now. There's also another playlist by Mendel Kaelin called Wave Paths, actually several playlists. And he operates out of Imperial College in London. And not only has he developed some playlists, he's in beta testing of an app that would allow you to tailor the music to the client's needs and their tastes. I actually spent some time in the introductory training to join the beta testing of that app yesterday. You can, it can be used not just with psychedelic therapy, it can be used with non-psychedelic therapy. Actually, one of their premises is music is a psychedelic. Obviously, if in my beta testing, I'm not going to be able to use it with psilocybin or MDMA because I can't do that at this time. Then therapist interventions. This involves manualized treatment, these studies, but they're not like nothing like the typical cognitive therapy manualized treatment. where you follow very specific instructions and rules. Most of the therapy is kind of non-directive and shaped by the therapist's knowledge of the effects of psilocybin. And also fairly often internal family systems are used, especially with MDMA. And Imperial College uses a lot of acceptance and commitment therapy, which is a kind of mindfulness approach to therapy that's very, the goals are very similar to the goals that you would have, that we have in psychedelic assisted therapy. Okay. So that's a brief summary of the practices and procedures. And by the way, I thought I'd make a few of these transitions kind of psychedelic. I thought that fit the theme of the presentation. So some research. I'm just going to hit a few highlights. The first research that the FDA approved was for people who were terminally ill, mostly with cancer. I think they kind of figured it couldn't do much harm, given the kind of dire situation of the patients. This isn't one of the first studies. This is a later study that's a little bit more rigorous than the early ones. But here they gave psilocybin-assisted therapy to 51 cancer patients. And it was, so they, each of them got both a high dose psilocybin session and a very low dose session that, more like the dose that would be used in microdosing, essentially, very much like a placebo. And the high dose sessions produced large decreases in measures of depressed mood and anxiety, and increases in quality of life, large increases in quality of life, life meaning, optimism, and pretty large decreases in death anxiety. In fact, the gains remained after 6 months. About 80% showed clinically significant decreases in depression and anxiety. And actually, close to 80% were no longer afraid of dying. Now, think about what a significant effect that is. Pretty much everyone I know is afraid of dying, and you find out you're dying and the fear gets worse. Almost 80% no longer afraid of dying. And the mystical experience, like I've said earlier, on session day, was the best predictor of the positive outcome. Here's a study of treatment-resistant depression, a fairly recent one, 20 patients with unipolar treatment-resistant depression. They got either a low dose or a high dose. No, they got both 7 days apart. And there was a marked reduction in depressive symptoms at 5 weeks, 3 months, and 6 months. And typically we use 0.05 level of significance or 0.01 level of significance in psychological research. 0.05 meaning these results could be due to chance 5 times out of 100. 0.01, 1 time out of 100. These are significant at 0.001 level, 1 time out of 1,000. It's a huge effect and it's studies like this that led the FDA to give breakthrough status to psilocybin. Here's actually a randomized clinical trial published just last November. It's a small trial, 24 participants. They had major depression. And to cut to the chase, there were large, rapid, and sustained antidepressant effects at the 0.001 level. Again, huge. And often in research, the early research looks better than the clinical trials. Here we have a clinical trial, the effect size is the same and huge. We just don't see things like this very often in clinical psychological research, to my knowledge at least. Here's a study where they combined psilocybin with meditation. And people got randomized to one of three different groups involving different doses of psilocybin and different levels of support for the meditation practice. And high dose psilocybin produced, again, large, significant positive changes in interpersonal closeness, gratitude, meaning and purpose of life, sense of forgiveness, feeling they had transcended death, daily spiritual experiences, and affected like their religious faith. And these results were both in terms of self-report, and they had community observers giving report as well. The two things that determined the effect were the mystical experiences and the rate with which people were doing their meditation or spiritual practice. And I think this shows that that psychedelic therapy and a meditation practice, a kind of mindfulness practice, can be possibly synergistic. Here's another recent study just from late last year. This was out of Imperial College. And so the following factors, and this is partly a review of the existing research, the following psychological factors have been found to be altered in an enduring way by psychedelic assisted therapy. Personality. Now, how often do you see personality changes based on short-term therapy? Trait openness, mental health and well-being, political perspective. That's kind of interesting. Lifestyle preferences and feelings toward the environment and nature. So once again, just the importance of the mystical experience. In one study, 61% of the volunteers had a complete mystical experience based on the Pankey-Richards Mystical Experience Questionnaire. And, many had a not complete, but significant mystical experience, many more. 67% of the subjects rated their psilocybin experience as either the most meaningful experience of their life or in the top 5. Huge. And many people have asked kind of an interesting question. How can one experience, no matter how profound, no matter how meaningful, make depression vastly better, maybe even go into remission and maybe change the course of someone's life? And Roland Griffiths has a really interesting answer. He says, we don't question that a huge traumatic experience can have a negative effect on the rest of someone's life. So why can't a hugely positive, meaningful, profound experience have the opposite effect? How does it work? We've only got about 5 minutes left, so I'll cover as much of this as I can. And this is going to be mostly about the neuroscience. So the default mode network is implicated in this. And the default mode network is a large scale brain network that connects a lot of different parts of the brain. And it's active when we're daydreaming, when we're thinking about ourselves and others, when we're remembering the past or planning for the future, or thinking about autobiographical things, reflecting on our own emotional state, when we're experiencing empathy. And it's considered to maybe be the neurological substrate for the self or the ego. It's thought that it may have evolved to allow our extremely complex human brains to operate more efficiently by operating mostly on habit. So The fMRI studies show the default mode network is quiet or downregulated after people take psychedelics like psilocybin. So it's almost inactive. They also show that the fMRI of studies of people who have taken psilocybin look remarkably like the fMRIs of Tibetan monks who are meditating. And that maybe explains somewhat the mystical experience. So here we have two representations of the interconnectedness of the parts of the brain. The one on the left is what our interconnectedness is typically like. And there, the default mode network is active. The one on the right is what the interconnectedness is like with the default mode network quiet. The interconnectedness in the rest of the brain goes off, as you can see, is absolutely off the scale. So it looks like the default mode network is restricting the interconnections in the brain during our typical daily consciousness, as you can see in the left picture. And that brings us back to Blake. If the doors of perception were cleansed, everything would appear to man as it is, infinite. For man has closed himself up till he sees all things through chinks of his cavern. Remember, our eyes, ears, and noses aren't our only organs of perception. The brain is an organ of perception, and it filters, organizes, and interprets what we perceive. So if the default mode network is inactive, and our perception is less filtered and less interpreted, and the brain is functioning in a more holistic fashion, is that the same as having the doors of perception cleansed? Does it allow us to see the infinite rather than just seeing through chinks of the cavern? Back to the neuroplasticity. All psychedelics promote neuroplasticity. And also that includes MDMA, the entactogens. It increases dendritic arbor complexity, promotes dendritic spine formation, and stimulates synapse formation. So one takeaway from this is it looks like psychedelics aren't antidepressants in the classic sense. What they appear to be is neuroplastic agents that open up possibilities for change. And then let me try to get through this. This is pretty interesting. This is also from Robin Carhart Harris's work at Imperial College. So like SSRIs and SNRIs, antidepressants work through the 5-HT1A receptors, different receptor than the psychedelics. So it's believed that stress naturally causes activity at these receptors, separate from antidepressants. So if we're under stress, it appears that our body naturally activates these receptors. It has a calming effect, a leveling of mood. And serotonergic antidepressants hack this system. They artificially enhance it. And so effective treatment results in less distress over upsetting things and appears to mediate a kind of passive coping. Psychedelics operate on the 5-HT2A receptors. Separate from psychedelics, it's believed that severe enough stress causes the body to naturally go from the 1A to the 2A receptors and start activating them. And there's some evidence that the 2A receptors cause a reduction in experiential avoidance. So we are less likely to avoid depressive or anxious thoughts and affect. And people with clinical depression and severe anxiety disorders do a lot of experiential avoidance. Also reduces behavioral avoidance, so kind of pushes the individual to deal with stressors. So it appears to mediate an active coping with stress. And psychedelics hack this system or artificially enhance it. I guess the last thing I'll get into, and this system seems to trigger something called pivotal mental states. And pivotal mental states are transient, intense, hyperplastic states of mind that have the potential to initiate rapid, major, and potentially enduring psychological change. And again, severe stressors, chronic stressors, and psychedelics trigger this system. And so severe traumatic experiences and peak experiences and spiritual experiences and psychedelic experiences can be viewed as PIMS. This may explain traditional spiritual practices that are stressful, like fasting, sweat lodges, intense meditation retreats, even the use of self-flagellation. Some monastic orders teach their monks to literally whip themselves. We have thought of that as masochism, but this research is suggesting they may have known what they were doing without knowing the neurology, and that those practices trigger the 5-HT2A system and these pivotal mental states, these transient, intense, hyperplastic states that initiate change. Last thing I guess I'll get into, pivotal mental states are not intrinsically healing or harmful. They're a psychological crossroads, and they can lead to personal growth and healing or to harm and even, severe mental disorders, which is why set and setting are so important in psychedelic therapy. And, going back to my examples, Bill Richards' crossroads led him in a wonderful direction. My friend Charles, that's not his real name, had the exact opposite happen. And so the importance of real attending to set and setting and skillful therapists, there have been no significant adverse events in the research so far. But this highlights just the importance of setting, the skillful therapists, the music, and have implications for the responsible use of psychedelics. And I guess I should stop there and go to questions. And I can stay for as long as you all and our organizers can be here. So looking at questions, see one here, is psilocybin recommended or not recommended for treatments receiving traditional SSRI, SNRI? Good question. Actually, they probably won't work for someone who's on an SSRI or SNRI. It appears that the little research we have shows that someone who's on a serotonergic antidepressant will have little or no response. Yeah, Daniel Barton just put in the list. It'll blunt the effect of the experience. A whole lot. So, yeah, the name of the program, California Institute of Integral Studies. Yeah, so if anyone's interested in Robert DeSalvo's talk and other NPI talks, they're up on the YouTube channel, and this one will be. Actually, I want to go back to my share screen for a second. Hang on, because there is something else I want to share really quickly. All right, let me jump to the end if I can. And there's more here you all can look at. So here's the information on California Institute of Integral Studies. You can also get training from MAPS, the Multidisciplinary Association of Psychedelic Studies, USONA Institute, and Compass Pathways. I'm going to start a study group. So if any of you are interested in joining the study group, here's my email address, or one of them, and my website. And also, we can have this discussion for as long as we can. But Robert DeSalvo, Lindsay Weiner, and I are going to host a follow-up discussion a week from Sunday. And this is the Zoom information. It'll be on Zoom. And you all will get this. So, oh, also, I may as well say, now that I'm done with this, the CIIS program, which I just finished last month, I have room for more clients. So I am taking referrals.